Pharma Pharmaceutical Consultants and ProData Analytics. We're delighted to have a chance to talk to you today. We're going to try something different today, and we love to talk about ideas, and we're going to have Alex Hernandez from our staff who's going to host and lead us, and I'll turn it over to Alex.
Hello everyone. We are here today to talk about the American Health Care Act, otherwise known as the AHCA. Just a brief, history about it. The AHCA was created due to problems with the Affordable Care Act stemming from high deductibles, soaring premiums, and limited options for consumers. I have about 3 to 4 questions for Dr. Stern that focuses on how this bill affects healthcare costs. So Dr. Stern, what does the AHCA, as we know it today, do to healthcare costs in relation to state-funded programs like Medicaid?
Well, number one is it'll require us to find out what they do with Medicaid, because the general plan is to remove all of the current exchanges and effectively then leave all of the Medicaid programs to the states.
Right.
Currently, there are block grants where the federal government pays approximately half and the state governments pay approximately half, and that pays for what programs go on in the state and expansion of the Medicaid programs within the state under the Affordable Care Act. Now, they're going to give the block grants. It's not quite clear whether the states can afford it.
Right.
It's not quite clear whether they'll be able to maintain or even uphold even the non-expanded Medicaid programs.
Right.
And a few of the states, like California, have said that they want to maintain it, so then there'll be a greater emphasis for the state in trying to come up with the funds necessary to pay for those programs. At the end of the day, these programs are necessary, and each of the states has a requirement to provide it. If the exchanges go away through the repeal of the Affordable Care Act, then many of those patients who move to any of the Medicaid programs will come back to the states, and the states will have to fund it entirely, whether it's under a plan in the state or it's by the state itself. If they do that, then the question will be, are they budgeted and can they handle it? And finally, there's been a discussion about ensuring that Medicaid has requirements for working and that they remove people and have put limitations on it.
Right.
Those kind of things happened under the Clinton administration, so it's not a new concept. It's not entirely a new idea. It's been going on, and perhaps even before the Clinton administration. But more importantly than not, when they do that, then there'll be a question about can the states deal with these right to work issues with regard to assets as to whether they can be part of Medicaid, and then bringing the whole thing back to the state and whether states can afford to deal with their Medicaid programs.
Right. And you had mentioned a couple of changes that the AHCA plans to do with Medicaid.
Mm-hmm.
Another change was you had mentioned the block grants, and I know some states, or I think all states, have open funding to help fund their Medicaid program. What does that mean for the states, just in regards to the block grants? Because I know they have a certain a flat tax they were proposing, right?
Right.
It was I believe it was around $4,000 for over 60 and $2,000 for the 21 and over, right?
Yeah, I think the ultimate goal here is to try and figure out an inexpensive way for people to afford healthcare insurance.
Right.
One difficulty is that the cost of providing Medicaid programs is significantly more than $4,000.
Yeah.
So in that regard, trying to deal with the cost of it through these restricted payment mechanisms means that people will either have to come out of money from their own pocket, but when you're talking about Medicaid, there isn't a lot of money for them to come out from their own pocket.
Right.
So as a result of that, it's going to be underfunded, and then the question will be, where will these people go? In the past, before the Affordable Care Act, before 2008 or so, people went to emergency rooms.
Right.
People went to the more expensive sites of care to get care versus going to a doctor's office where they'd have to pay. So in that regard, this could be a significant burden on all of the states, because none of the states were able to fund their own and able to make it in and of themselves and how they dealt with it. And furthermore, the issue will be for all of them, how do you deal with a program, even for the younger people that they want to offer something inexpensive? You can't really buy much health care for $2,000, even in the savings accounts that have been discussed.
Right.
They require that you spend $2,000 to $2,500 on a catastrophic policy, and then the rest of the money used for health care. Well, if it's $2,000, you're using up all of that you would have spent on the catastrophic policy, and there's nothing left. So then the question is how are you going to follow all these people, and how is it going to be addressed? So it becomes a problem as to how it's going to be funded, and effectively healthcare people, and we're healthcare people, we have to treat people as they are admitted, as you see them. If they're sick, we treat them.
Right.
In this particular case, there will be a major issue about how are you going to afford to treat them when we have, in fact, a mandate to treat them.
Yeah. Okay, well, let's move off the Medicaid part of it.
Mm-hmm.
Just focusing on the AHCA itself, are there any provisions within the AHCA to help control the cost of drugs?
No, there isn't. There is a hope that the administration will negotiate with drug companies in order to deal with lowering costs somewhere along the lines of they would lower costs along the lines of how much is paid for the VA patient for their drugs or for Medicare and its drugs. However, no, it doesn't occur today. And so on one level, that becomes a problem. How do you go about doing it? There isn't a push-pull argument going on between health plans and PBMs today that they're already negotiating. They're picking up discounts through rebates, etc. It's not going directly to the patient, so it's hard for a patient to know if that discount is really appearing in what they pay or not. Right. And then separately, there's an issue with regard to the other side that is saying that you have to get the government involved, and the government is the biggest payer, so therefore they can get the biggest discounts. So that becomes a big issue. The other thing that is not being addressed, and it's not being addressed, it hasn't been addressed as of yet with regard to the Affordable Care Act, it hasn't been addressed with regard to the American Health Care Act, etc., is the cost of drugs is rising dramatically in specialty medications. We're moving from drugs that cost for brands somewhere in the range of $135 for 30 days to drugs that cost on average $1,500 per dose. So if we don't do something about that cost, regardless of what the healthcare plan is and how to make it affordable, then all programs will become unaffordable for the consumer.
Right. And what role do manufacturers usually play in this?
Well, manufacturers are instrumental in coming up with new drugs and in driving it. Their argument has been that they don't have as big of a price increase as has been published, that it's really taken up by rebates and discounts from the PBMs and the health plans. The PBMs and the health plans have argued that no, it's the pharmaceutical manufacturers that are driving price. Clearly, there's arguments on both sides, and clearly there are problems on both sides. The manufacturers, though, have an obligation to make sure that drugs are available, and there clearly has been shortages of major drugs, both brand and generic, over the past several years, and frequently hitting hospitals where they're absolutely needed for surgeries or intensive care units, etc. And then the other part of this is that the drugs themselves, there has been some surveys that have identified that about 63% of patients would rather have innovation than lower cost drugs. So there's also a move by patients to say, we would rather have new drugs that are more influential than the older drugs for used for whatever purpose. Frequently, that argument clinically doesn't hold because the older drugs do just as well as anything new, and the way that they're being evaluated now with non-inferiority trials is effectively saying my drug is no better and no worse than yours. It's just the same, but it costs significantly more. So those arguments need to be addressed by people. And finally is this issue of the cost of drugs is driven not only by the cost of drugs, but also new genetic tests and others that are given along with it. So the cost expands in order to deal with all of that.
Very interesting. Very interesting. We can go more, but looks like we're out of time. Thank you guys all for watching. We want you to visit the ProPharmaConsultants.com. On there you'll find the RX InfoX, which is our free information page, which we gather information from a variety of sources and put it all into one page for you, completely for free. We will be off for the next 2 weeks. We'll be back on April 12th. Please make sure you like, share, and subscribe. And any comments or questions you have, please leave them below the video. Thank you very much.